What makes a state healthy? Certainly having access to high quality and affordable health care is one of the requirements, but there are so many other things that are necessary for health, like having secure access to food and housing and an adequate income, having care for the elderly and people with disabilities, mental illnesses and addictions, and protecting vulnerable children and adults. And there are many others too, numerous to name. Minnesota is a healthy state because most Minnesotans have access to all of these services. And much of the effort in each of these areas, and many more, is led by the Minnesota Department of Human Services, the state's largest agency, serving over 1 million Minnesotans in all 87 counties and 11 tribes. The Minnesota Department of Human Services plays a major role in protecting and improving the health of all Minnesotans. So on today's episode of A Public Health Journal, we'll be discussing many of those roles and activities. Please stay tuned.
Welcome to A Public Health Journal, a program that explores public health issues facing our society today and tomorrow. The host of the show is Dr. Ed Ehlinger, Commissioner of Health for the state of Minnesota. A Public Health Journal is sponsored by the Minnesota Department of Health and the Hennepin County Human Services and Public Health Department, all working together towards the goal of healthy people living in healthy communities.
Welcome to A Public Health Journal. Today we're going to look at some of the activities of the Minnesota Department of Human Services that help protect and improve the health of all Minnesotans. The Department of Human Services, or DHS, is the largest state agency with a portfolio that includes Medicaid, Minnesota Care, long-term care, mental health, substance abuse, food stamps, and many, many more. DHS works in all of Minnesota's 87 counties and with all of the 11 tribes in the state. Joining me in this discussion is Emily Piper, Commissioner of the Department of Human Services. Commissioner Piper previously served as Governor Mark Dayton's General Counsel and Deputy Chief of Staff, advising the Governor and his administration on legal matters. She has also been Deputy Commissioner and Chief of Staff for the Minnesota Department of Commerce. Emily, welcome to our program.
Thanks for having me.
You know, one of our sister agencies, and I always am remarkable. I think you have the toughest job in state government, running the Department of Human Services. It's a huge agency with a reach throughout the state and many really difficult issues. Given that scope and breadth, how do you describe your agency to the general public? And when you say, here's the Department of Human Services, this is what we do.
You know, usually when I'm talking to people, they don't really understand what the Department of Human Services does or is, and so I explain that it's a statewide agency that helps serve over 1 million people, most of the time through social services programs. We also work with counties to provide those services across the state. We talk about our state budget and how DHS and our programs are a third about of the state's budget in any given year. Providing care and making sure that people who need it can receive the services that can help them live in dignity and reach their highest potential.
Yeah. So what, when you talk to your staff, what do you say? This is our mission, this is our vision, this is what we want to do, in just that, little thumbnail. What do you talk to your staff about?
Well, our vision is, and our mission statement is to serve people in the state of Minnesota in a way that helps them reach their highest potential, helps them live in dignity. And so all of our services are really person-centered, geared around those goals that we have for the people we're serving.
Right. Now, in my introduction, I mentioned that there are a whole variety of services and programs that you run, and we couldn't deal with that in a half hour. So I've decided that we should probably look at 3 issues, mental health, substance abuse, and sort of healthcare reform. So let's start with mental health, because this is one of the major things that you do, right? How are you organized to deal with mental health issues in your agency?
Well, we have a few different ways. We're a payer of mental health services through Medicaid and Minnesota Care, which are our state public health care programs. We also spend a lot of time and effort issuing grants and setting public policy around best practices for mental health in the state of Minnesota. And then we also are a direct treatment provider of mental health services, serving those individuals, those people who can't be served by private providers for really significant mental health issues across the state.
And I've got a slide here that shows that in the past year, 1 in 4 adults and 1 in 5 children experience mental illness. So this is a huge problem in the state, isn't it?
Mental health is a huge problem, and access to mental health services is a huge problem in the state. We know that every year about 200,000 adults in the state and 75,000 kids in the state suffer from a mental health challenge, and we also know that it takes, on average, about 10 years for a person to access the mental health services that they need. And one of the really sad parts about that is that mental health treatment is really effective, and so when people do access services, the services and the treatments are really effective to help them live a really the life that they want to and achieve the potential that they're seeking.
Now that raises the question, are there adequate services? Because you are really sort of a provider of last resort and a provider for really high-risk groups, but even in the private sector, there just don't seem to be enough health care, mental health resources available. Is that a problem?
Access to mental health services is a real problem in Minnesota and across the country. And the Affordable Care Act went a long way in driving parity in mental health, treating mental health just like any other health care condition that a person may have. But we do have really significant disparities in access and access to services, access to coverage in healthcare policies, and also depending on where you live or what your background is, you might be facing disparities in access because of those factors as well.
And I know mental health really causes a lot of concerns within the community, and we have a slide here that shows that fact if you have mental illness, actually your life expectancy is down dramatically, and not just because of the mental illness, but because of a lot of other factors. What's the reason people with mental illness don't live as long as other folks do?
Well, I think one challenge is, as I said, they don't access services and treatment that they need soon enough. And also, if you think about the impact mental health has on a person, it's not in isolation of the rest of that person's life. And so perhaps if you suffer from depression, you're less likely to go to regular checkups, physical exams. And so it really does have a downstream impact on the rest of your health.
Now, I know one of the things that you've been really pushing and developing are behavioral health homes. Tell us a little bit the thinking behind those.
Well, it really is treating mental health and treating people who suffer from mental health issues in a primary care setting. So you have more integrated services between mental health and your primary care. So you're not trying to go from doctor to specialist to doctor to specialist. You're really getting the treatment you need in the environment you need it when you walk in the door.
So you'll get at some of those physical health issues in addition to the mental health issues. And one last little thing about stigma. This has always been a huge issue with mental health. Are we making progress on reducing the stigma, having people talk about mental illness and people coming forward and it's saying, I need some help?
I think we are making progress. I think we have a long way to go in eliminating the stigma that people face when they're talking about mental health issues or feel when they're dealing with mental health issues. And it really is reframing how we think about mental health in the state, that mental health is just like any other health condition that a person faces. And part of treating it that way is making it accessible. When you have a heart attack, you don't go into the hospital and have the hospital say, well, in 2 weeks, we can get you in to check on your heart attack. And mental health should be treated the same way. And so we have come a long way, but we have a long way to go.
And I suspect you have lots of partners throughout the state working on mental health issues, that you're not doing this alone.
Yeah, we're really fortunate in Minnesota. We have a robust nonprofit sector. We have counties and tribes all across the state that are working on this. The governor's created a mental health task force that includes law enforcement, community service providers, the court system, and inpatient psychiatric professionals, all coming to the same table to try and find solutions for the benefit of the people of Minnesota.
Right. Well, a related issue is substance abuse. It sort of links with mental health, and we'll talk about that in the next segment. But first, we need to take a little break. Okay. We'll be back right after this message.
Good news, everybody. People are living longer than ever before, which means most of us can look forward to more years doing the things we enjoy, if we plan ahead. That's because, at some point, the vast majority of older Americans are going to face a physical or mental disability, and they're going to need some help. In fact, there are more and more young people who face the same challenges, which costs money, and health insurance and Medicare don't always cover it. That's why it's so important to make a plan, and to address a few key questions. First, do you want family or friends to take care of you? And are they willing to do it? Do you want to stay in your home? If so, does it have a bedroom, bathroom, and kitchen on the same floor? How about in-home care, assisted living, or a nursing home? How much is it going to cost, and how are you going to pay for it? And of course, what are your preferences regarding end-of-life issues? Have you written them down? Yes, these are complicated questions, but not to worry. This website has everything you need to make informed decisions. So look around. It'll help make those bonus years the best they can be.
Welcome back. We're talking about the impact that the services that come through the Department of Human Services makes on Minnesota's health with the commissioner of that agency, Emily Piper. Emily, mental health, a big issue, and as I said, related to that is substance abuse. We have a lot of issues related to alcohol and other illegal drugs, but particularly recently we've had some concerns about opioids and heroin and a huge spike on this. And I actually have a slide here that shows what's been going on over the last several years with opioid deaths. So maybe you could explain a little bit about what's going on in this slide to sort of frame the magnitude of the problem.
Well, we have, over the course of the last several years, seen a really significant increase in opioid use and opioid death. And so this slide shows the top line really is the increase in trend for opioid deaths in the state of Minnesota. And we look at that as part of the alarm bell that we're sounding as a state, saying this is a huge problem, it's a growing problem, and it's a problem impacting a lot of different populations across the state, and one we need to tackle.
Right, and related to that, as the end of that slide, there's also an increase in heroin deaths. So how are those related?
Well, we know that when people become addicted to opioids, that is a gateway drug to heroin. And so when people lose access to opioids, either through their pill shopping, doctor shopping, and that's not working out, they really turn to heroin as a secondary drug that they'll use.
Is this part of the use of prescription drugs as an entry place? Because I know certainly we talked a lot about adolescents getting access to their parents' medicines and becoming addicted. Is this part of that? It's a prescription drug issue in addition to an illegal drug issue?
That's what makes it, and that's what makes it so scary, and makes it scary for young people in our community where they have legal access to these drugs and they become addicted. You get your wisdom teeth out and you get prescribed opiates when you're 17, 18, 19 years old, or have knee surgery, ACL surgery, and you become addicted to opiates. And it really is, we're seeing acting as a gateway drug into illegal drug use for our young kids.
And I know you've been working with a variety of partners on this and with the tribes, because it's a huge issue within the American Indian community. What do you think, what are people saying is, why has this become such a problem in the last 10 years? What's changed in our society?
Well, I think one of the challenges is that one of the things we've seen are prescribing practices by prescribers changing, and people are having more access to longer term prescriptions for these really powerful drugs. And so one thing we're working on at DHS is drafting prescribing guidelines, because prescribers that are prescribing these drugs don't always know what best practices are for how people should be treated, how long they should get a prescription for. And so we're really working on a best practices model for prescribers to follow in the state.
And I suspect you have a lot of power in making some of the, since you pay for a lot of the services and you're dealing with a lot of these folks, that the impact of those policies would make a huge difference.
We're hoping that it'll be a positive, that prescribers will look at our guidelines as a tool they can use, but we do have a lot of power in that. We're a significant payer, and one of the ultimate tools that we have is really not having providers access payment for Medicaid benefits if they're abusing the prescribing practices that and the guidelines that we've established that we think are best practices for the people on Medicaid and Minnesota Care.
So in some ways this is a problem that we helped create in the healthcare community, but we're also trying to deal with it the same way. What about the prescription drug monitoring program through the Board of Pharmacy? How does that work?
So the prescription drug monitoring program is a really great program, and they're all across the country where prescribers can access and see, if a person's doctor shopping, where they're getting other prescriptions from. One of the challenges we have in Minnesota is that our prescription drug monitoring program's been voluntary, and so it's been difficult to be as robust. We've had difficulties getting it to be as robust as other states where it's mandatory.
Mm-hmm. And the other piece that has gotten a lot of attention is with these large number of overdose deaths, there is an antidote, something that bring it back, naloxone or Narcan. How is DHS engaged in getting Narcan out into the community to folks who can use it?
Well, we spend a lot of time working with communities through grants and other functions to make sure that Narcan is accessible to various communities. And we've seen some success, particularly in our Native American population, where we know there are some real disparate impacts on those people on reservations and in urban Indian communities, making sure that the organizations have grant funding to allow them to buy Narcan to be accessible to the people living on the reservations or in their urban Indian communities.
Yeah, and I know that a lot of folks see illegal drug use as a law enforcement issue. So how do you work with the Department of Public Safety and law enforcement on this issue to say, many times the addiction is a medical issue and needs to be treated as an addiction, but it's also illegal. How do you balance that with your partners?
Well, I think it's always a challenge, and I think one of the hardest examples is moms addicted and babies born addicted to opiates. I can't imagine the pain a mother feels when she's pregnant, taking a drug that she knows is going to negatively impact her baby. And we know in our Native American population, a baby born is 8 times more likely to be born addicted to opiates than a Native American baby is than a white baby on Medicaid. And with those disparities, we just know that criminal prosecution is not the answer for the users, these mothers, these young people. They're not criminals, they have an addiction. And it's really working with law enforcement to differentiate that circumstance from the pain pill dealers selling drugs on the black market.
Yeah, because it's a whole different kind of frame than we've had for some of the other drugs. And I know that anytime you criminalize something, people who are vulnerable oftentimes don't come in to get treatment because they're afraid of what's going to happen. I suspect the same thing is going on here.
It's really challenging, and we see a lot of people not seeking treatment right away, and really not seeking treatment until they turn to the gateway drugs like heroin to go into recovery. And one of the challenges is that if you catch if you go into treatment early, your chances of being successful in that treatment are a lot greater.
Right, good. All right, I want to talk lastly about healthcare, which is the big part of your portfolio, but first we need to take another little break. Okay. So we'll be back right after this message.
Now I need you to tell me again what happened.
Excuse me, sir.
So what do you got?
Someone came forward. That's who we thought it is.
I'm sorry. What? Come on.
Your grandpa's gonna be all right. Dad, it's gonna be okay.
Look, this is
Okay.
Welcome back. We're talking with Emily Piper, Commissioner of the Department of Human Services, about some of the programs that she's responsible for in the state of Minnesota. Emily, one of the biggest areas, and certainly is in the news a lot, is health care and access to health care, and certainly in your agency with your responsibility for Medicaid and Minnesota Care. You have a lot of involvement in it. So sort of frame your role in all of the activities, particularly starting back in 2011 when the governor expanded Medicaid, and it increased the access to a whole bunch of folks. What are some of the things that are churning in your department around healthcare and healthcare reform?
So our healthcare area, just to give some context, DHS's annual budget is about $18 billion. And our Medicaid and Minnesota Care and related programs makes up about 76% of that budget. And we serve about 1.2 million people a year through our public health care programs. And some of that growth is really because of the governor's decision to expand Medicaid and expand health insurance coverage to a whole bunch more Minnesotans, hundreds of thousands of Minnesotans that didn't have access before. And so we spend a lot of time and a lot of effort at the state and also through county partners trying to look at ways to do healthcare better. And part of health reform has been looking at innovative different ways to pay for healthcare and access to healthcare for our people that are on our healthcare programs.
So explain how Medicaid and Minnesota Care and private insurance work. Who gets what? Who has access to those different kinds of things?
So, there's different requirements or different qualifications for people based on their income. And the lowest income people in the state of Minnesota receive Medicaid. Up to 138% of federal poverty is just the general ballpark. And there's some exceptions to that. And then if you qualify for Minnesota Care, it's about 200% of federal poverty line that you is your income that qualifies you for Minnesota Care. And then beyond that, you can you buy private health insurance, and depending on your income, it's scalable that you can qualify for tax credits under the Affordable Care Act to subsidize the cost of your private health insurance plan.
All right, so I think people generally know about Medicaid. It provides really good comprehensive care, and we may come back to that a little bit. Minnesota Care, for those people who can't quite afford private insurance but make a little bit too much money for Medicaid, what kind of services do they get in Minnesota Care?
Minnesota Care is a really robust health insurance plan, and it really is designed for sort of what people would think are the working poor in our community. And it's a comprehensive health insurance policy that provides really great health insurance coverage for people in the state of Minnesota.
And then how did your programs fit with MNsure, the marketplace through the Affordable Care Act?
So MNsure really is a place where people can see if they're eligible for our public health care programs. People can go and buy health insurance on their website, and depending on the income that they enter and other questions that they answer, MNsure can help guide them to whether or not they qualify for Medicaid or Minnesota Care, or a qualified health plan it's called, which is really a private health insurance plan, and whether they qualify for tax credits.
So MNsure doesn't set the prices of things, as I know they've been getting a lot of heat about the rising costs, but what are the reasons costs are rising?
Well, I think one of the challenges it's really the individual market that we're seeing the most significant cost increases. So those are people that don't have health insurance through their employer, aren't on Minnesota Care, aren't on Medicaid. And one of the challenges we have with that population, I think, is that it's about 5% of the whole market in the state of Minnesota. And many of the people that are on the individual market used to be in what was called APHJ, was the state high risk pool. And so there's a huge number of people, or a bigger number of people in that health insurance pool, in that risk pool, that have really significant health coverage or health conditions that drive up the cost of their care.
Right. So the fact that we've segmented our market into smaller units doesn't give us the breadth to really share costs, share the cost of healthcare across the broader population that's causing some of the problem.
Well, it's the segmentation, but then it also is that we're covering everyone, that insurance companies can't deny people insurance based on pre-existing conditions, and women can't be charged more for health insurance than men. And so although it's costing more and it's really challenging for people, and there are real needs in reform in the market, more people have health insurance now than have ever had health insurance in the state's history, and that's a real success of the Affordable Care Act.
Well, that's a good thing, and certainly I won't ask you about public option and single payer because that's sort of my deal, but but there are lots of things that we can do and I know we're working on, and you're certainly working on a lot of those. Emily, we've come to the end of this time. This is covered a lot of ground. You did a nice job of sort of explaining what DHS does. Thank you for the work that you're doing and for helping working with me to help keep Minnesota the healthiest state we can possibly have.
Well, thank you.
Good. And I'll be back with a closing comment right after this message.
Most of my family, they never graduated high school or even let alone go to college, so I'm trying to break that barrier. Every day after work, went straight to school, studied hard, and it paid off. I could not have done it alone. I see the future is really bright for me. The high school diploma is just added to the confidence, and now I feel unstoppable.
Find free adult education classes near you at finishyourdiploma.org.
One's health is determined by multiple factors. Certainly one's genetic makeup is important, along with access to high-quality medical care. But other factors are also important. Things like one's environment, social and economic circumstances, and individual behaviors. And as I look around this country and around the world, I've noticed that the places where the people are the healthiest are the places where all of these health-determining factors are addressed in a comprehensive and integrative fashion, not in an individual or isolated fashion. Places where people are the healthiest have effectively integrated medical care services with public health and social services, and have delivered these integrated services in an educational, physical, and social environment that supports health. Minnesota is one of the healthiest states in the country because we have also done a good job of integrating medical care, public health, and social services in a unique and effective way. The interactions between the Minnesota Department of Human Services and the Department of Health are a great model of this. Certainly there is more that can be done, but the interactions of these two agencies, along with many other state and community partners, are a good example of what the Institute of Medicine meant when it defined public health as what we do as a society collectively to assure the conditions in which people can be healthy. Optimal health for our state will not occur if we only work within our organization, agency, or special area of interest. Minnesota can become one of the healthiest places in the world only if we all work collectively to assure the conditions in which all Minnesotans can be healthy. That's all for today. Thanks for watching. I hope you can join us again next time on A Public Health Journal.